everybody. My name is Dr. Allison Ball. I'm a physical therapist with Sanctum Med and Wellness. I'm so excited for everybody to be joining us today. Today we get to have an awesome guest. It is Dr. Allyson Shrikhande with Pelvic Rehabilitation Medicine. So what we're going to be talking about today is pelvic pain and different treatment options, how to treat it from a holistic perspective. So we are really excited to talk about all things related to pelvic pain. So a little bit about Dr. Shrikhande. She is the Chief Medical Officer of Pelvic Rehabilitation Medicine, and she is a physical medicine and rehabilitation specialist. So she has focused all of her time and energy into treating people with pelvic pain. So we are going to go ahead and bring her in. I'm so excited for y'all to meet her. So here we go. Let's see. Hi.
Hello.
How are you?
Good. How are you?
I'm doing great. Well, thank you so much for joining me today. I'm really excited for our conversation. I think it's going to be super fun.
Thanks so much for having me. This is great.
Yes, I'm so excited. So I'd like to start, if you don't mind, just introducing yourself a little bit and telling us a little bit about your practice.
Sure. My name is Allyson Shrikhande. I am a physiatrist, and we are physical medicine and rehab docs. And I co-founded Pelvic Rehabilitation Medicine with my husband in May of 2017. And we started off in New York City, and we are currently expanding to multiple cities throughout the country to just help really take a new look at an old problem. We treat chronic pelvic pain syndrome, men and women who have chronic pelvic pain and pelvic floor muscle dysfunction. So we talk a lot about bladder, bowel, and intercourse.
Yeah, that is awesome. And you said y'all have 10 locations now across the U.S.?
Yes, we have 10 locations. Okay. Yes, we're in New York City, we're in Miami, we're in Detroit, Washington, D.C., as well as Dallas, Houston, Chicago, and Atlanta, and then New Jersey, Englewood, New Jersey, and out in Long Island.
Okay, awesome. That is great. So and for people who don't know who I am, I'm a pelvic floor physical therapist, and I'm the owner of Sanctum Physio, which is a part of Sanctum Med and Wellness. It's a practice with myself and a gynecologist, Dr. Jessica Shepard, and a yoga instructor, Georgette Dunn. So we're opening a practice all together, and we actually are going to be really close to the Dallas location of Pelvic Rehabilitation Medicine. So we're really excited to collaborate with y'all, because I think all of our approaches really go hand in hand as far as treating pelvic pain.
Oh, completely agree. Yeah, no, I really enjoyed hanging out, chatting with you about your treatment approach, and the synergy is just amazing between us.
Yes.
The approach that we will take.
Absolutely. So tell me a little bit about like what y'all's treatment approach is, and kind of what PM&R is in general.
Yeah, no, right. So PM&R is not a well-known specialty. Essentially, we are non-operative physicians who treat the muscles, nerves, and joints. And at Pelvic Rehabilitation Medicine, we just focus on the pelvis. That's what's unique about us. So we treat the muscles, nerves, and joints of the pelvis non-operatively. So essentially, we treat a lot of pelvic floor muscle dysfunction, a lot of postpartum issues, or patients who have a history of anything underlying gynecological, such as endometriosis, get a lot of muscle nerve issues, any underlying hip pathology, hernias, a lot of gastroenterology issues, such as IBS, ulcerative colitis, Crohn's can cause a lot of pelvic floor muscle spasm and the nerve dysfunction, as well as urological. So we see a lot of bladder pain syndrome, interstitial cystitis, but we're treating the secondary muscle nerve dysfunction that can come with these underlying problems.
Yeah, I think it's so interesting, because PM&R and pelvic floor PTs, I think, have a very similar experience. And when you tell people what you do, people are like, never heard of that. It's pretty unknown, but it's I think it's such an important specialty on both ends because we're able to, like you said, take a much more conservative approach to treating chronic pain, which is really hard to find.
100%. Yeah. I mean, I always describe us, we're rehab docs, we're rehabilitating the pelvis, and we're really extensions of pelvic floor physical therapists. So we're the MDDO counterpart to a pelvic floor physical therapist, but we work closely with you guys, and we work together to get our patients better.
Yeah, I think what's really cool is that we have y'all to do the medical intervention part. So whether they need medication or injections, things like that, then they have y'all to do that, because obviously we don't have prescription rights, things like that. And then we can take the time to see them weekly, things like that, to really rehab those muscles and change any lifestyle factors that need to be addressed. Can you tell me a little bit about the injections y'all do?
Sure. So the injection protocol, so what it is it's outpatient, ultrasound guided, peripheral nerve blocks with the hydrodissection technique, which really just means it's a high volume technique to increase kind of space and blood flow to the nerves, with a concomitant trigger point injection to each muscle of the levator ani sling. It's pretty subtle. People go straight to work. You'll see us 8:30 in the morning, you're at your 9:30 or 10 o'clock meeting. There's no downtime, but it's kind of a trip around the pelvis. So typically we do one side at a time, and it's once a week for 6 weeks. And you see us with pelvic floor PT in conjunction. So conceptually, we're really rehabbing the pelvis. We're not typical pain docs. So we're trying to really reset and retrain those muscles and nerves, is our goal, to decrease pain and improve function for patients. So we're kind of, the first part's a lot of down training, decreasing inflammation around the nerves, increasing blood flow, calming down any sensitization of the central or peripheral nervous system. And then after that, when patients are ready, it's a neuromuscular re-education, where we're really trying to get that lift back in the pelvic floor and work along the hip muscles, particularly the hip abductors, and then the deep muscles of the spine, to really get that stabilization to support the organs of the pelvis, and then support the joints as well. We want to support the hip, the lumbar sacral spine, the pubic symphysis. But that's conceptually what we're trying to do: reset, retrain. So it's a bit different approach in that it's external, not internal. And so conceptually, it's much more comfortable and safer as it's guided with ultrasound with a tiny needle.
Yeah, and I think that's something that a lot of people don't realize, is how like the nervous system and the muscular system go hand in hand. Like we could treat the muscles all day long, but if the nervous system is super upregulated, then we're not going to get very far with any straight muscle rehab. So I love that you said that neuromuscular part.
Yeah, completely agree. I always describe it as we have to have the nerves talking to the muscles appropriately. So it's not just strength we're looking for, it's really that neuromuscular coordination, I think, is a better way to describe it.
Yeah, it's always interesting whenever I see patients where maybe I see some weakness or just a lack of coordination. A lot of times they will get stronger, but it's not necessarily because the muscles suddenly gained a lot of bulk or a lot of new muscle fibers. It's just because the brain and the pelvis are talking to each other again. And so they end up seeing results a lot more quickly than you would if you were just strength training, since that takes 6 to 8 weeks at least to start to see big gains. But if you're just addressing that coordination part of it, and then all of a sudden things are talking to each other, then everything moves a lot more quickly and they see really good results.
100%. That's exactly right. Yeah.
And then the other thing I love about y'all's practice, y'all spend a lot of time with patients, especially on that first visit. Is that correct?
100%. Yes. Our patients classically have seen many physicians prior to getting to us, have been bounced around the system a bit. So yes, a lot of listening, and our treatment protocol is one of the things we're bringing across the country because it's unique and different than anything that's being done. But it's really also our diagnostic capabilities, in that, we're really trying to find the underlying pain generator and explain what is going on. So explain why they have, pelvic floor hypertonia or muscle dysfunction, explain why they have the pudendal neuralgia. So a lot of it's really getting to the bottom. We're detectives, just getting to the bottom of how they got there. And usually it's multiple things, but we really break it down and we just work on each thing individually and do the workup that's required. If it's imaging or referral to another specialist. So we look at ourselves as the quarterback and then we work closely. We need pelvic floor physical therapy to get patients better, honestly. And then whatever specialty, it just depends on the case, who we need to bring onto our team.
Yeah. Yeah, and I think one thing that a lot of people assume whenever they hear pelvic floor is that it's going to be postpartum women, but at least in the pelvic floor PT world, I'm sure you would agree with this, it's not just postpartum women, it's pregnant women, it's prepartum before they've even had any children, maybe even older adults and men too. I'm assuming you see very similar populations as far as that goes.
100%. Yeah, no, at this point we see 60% women and 40% men. But yeah, I mean, I started off, said women's musculoskeletal health, but the men came in for us, pelvic floor PT and rehab docs, the anatomy is the same for the muscle and nerves and joints. So for us, it makes sense for us to treat both, and we do. And so it's been great. It's been great to see both men and women. Yeah, it's been great.
Have you found that men and women present differently, like as far as symptoms go?
What we have noticed is men classically have a little more underlying musculoskeletal. So hip hernias, we see a lot of hip hernia combos in our men, more than we do in our women. And for our females, quite often it's either postpartum and or underlying gynecological. So over the years, that's kind of the data that we're gathering is women tend to have more underlying gynecological issues, endo being probably the most prevalent in what we see, and then have a lot of combination hip and hernia issues that can present with pain. They have pain with erection and pain with intercourse and issues with bowels, but then urgency, frequency, but you work it back, and there's a really large cam pincer in their hip, and they have a hernia either in the guinal region or obturator or femoral region pinching their nerve. So quite often there's a musculoskeletal component to their problem.
Yeah. One thing
how about you? How do you guys? What about your practice? Do you see them presenting differently?
Yeah, I think for men, one thing that I've seen really consistently is when they're having any signs of like pelvic floor tension. So whether that's like urinary urgency or frequency, or if they're having like testicular or penile pain, a lot of times they have a lot of abdominal tension and like fascial restrictions throughout the abdomen. Totally. And so usually if I do a lot of manual therapy techniques over the abdomen, and like you said, like the glutes are always super tight too. So we go to glutes and abdomen first, and then also working on diaphragmatic breathing, because men or women, we're not very good at using our diaphragms and we like to keep our tummies in tight. So I think that's a big problem for them. So sometimes if we just correct breathing and work on the manual therapy over the abdomen, they're like, oh, like now I'm not peeing every 15 minutes. And so it's interesting. I think because they're very, because it seems to be more musculoskeletal, like you were saying, I feel like they progress really quickly once we figure out what's going on.
Yes. No, I agree. I completely agree. The abdomen with the men, I completely agree. Yeah, because we treat the nerves of the abdomen quite often, the ilioinguinal, genital branch, and genitofemoral. And for the men, most always they do need to be treated. And I love when you work on, the abdominal fascia and the skin rolling techniques. And also sometimes we'll add acupuncture to our physical therapy prescription to help with the abdominal work for sure. I completely agree. What are your thoughts on the nerve gliding technique, on nerve gliding in general?
Yeah, I've seen it. I would say it kind of depends the person. So like if there really is true entrapment, it can definitely be helpful. The other time I've seen it be really helpful is if they just have a lot of fascial restriction, because doing the nerve gliding will really help free up that fascia that maybe adhering onto the nerve a little bit. And so I'll definitely use that for the pudendal nerve, especially, and sciatic, especially if they're having those classic nerve signs, like they're feeling tingling or numbness down to their toes, down the back of their leg, things like that. If they're kind of showing those classic nerve compression signs, then I'll start them on that. The other thing I'll have females do that seems to be helpful with the pudendal nerve is labial rolling. And so they're literally just like pinching the labia between their fingers and then just rolling back and forth for about 10 seconds, kind of going all the way around like a clock. And I've had patients get really good relief with that. So that's been a cool technique that is pretty easy for patients to do at home.
That's so interesting. That's really cool. It must be releasing a lot around the dorsal nerve, the fascial restrictions along that dorsal nerve. That's amazing.
Yeah.
I love that.
Yeah.
One thing we really had connected on was the importance of the treatment of the fascia, which I once you said that, I completely agree. I think that's conceptually what we're trying to do as well. It's really just increasing blood flow and breaking up those fascial restrictions. That's the key.
Yeah, I think it's overlooked a lot because I think a lot of people jump to, okay, if something hurts, it's just tight. It's just tight muscle. Well, we can stretch the muscles all day long, but if there is tight fascia, which really the main ways of treating that is doing the manual work, either through manual work like with my hands or dry needling, or like you said, acupuncture can definitely be super helpful there. I also have a massage therapist that I refer people to a lot that really focuses on the myofascial work. But I think that's what sometimes is missed, especially in the PT world, is if we're not thinking about the connective tissue part, and that's what's surrounding the muscles, we can stretch all day long, but we're not going to get very far.
Yes, completely agree. Completely. I love that that's your thought process. Yeah, and we seem to share that integrative, kind of holistic approach to patients and how we treat them.
What are like the main lifestyle modifications that you recommend to patients?
Yeah, so it's individually tailored to really a lot of listening on their history. But couple examples for exercise, if someone is a spinner or a bike rider, sometimes we'll modify that, have them take a break until they're ready to go back, make sure we get them a proper seat when they do go back that's kind of fitted so it doesn't put pressure on the pudendal nerve. Is an important one. We quite often are asking patients to get a cushion. Seat, cushion your assets are good ones. But really conceptually, it's really just so that when you're sitting, that the blood flow to the pudendal nerve remains, right? Because if you sit and you put pressure, there's an ischemia. So cushions are a big lifestyle modification that we talk about. We really just go over, what their exercise. We like to keep patients moving overall. So physiatrists are really similar to sports doctors, outpatient sports doctors. So we love talking about exercise with patients. So it's what they like to do, right? Because no one's going to do something if they don't enjoy it. So it's a lot about what they like to do. And then we try to make sure it's safe, try to get them doing what they love. And sometimes it's within kind of just moderation, depending on what it is. And we talk a lot about, we like a specific yoga program, particularly when patients get better, right? When they're a lot better and they're ready to go. Dusty and Miller's Europace Yoga or Adrian's yoga for the pelvic floor. Both kind of conceptually do a lot of that diaphragmatic breathing that you were discussing, and they really get that nice neuromuscular lift. And patients don't really know they're doing it. It's just a nice yoga program. So those are common ones. We talk a lot about nutrition. Bowels are big for us, right? Because constipation's the enemy of the pelvic floor. So a lot of magnesium citrate, the capsule form we tend to like, 400 to 800 milligrams, or psyllium husk. Lots of water, keep hydrated. Talking a lot about different diets, IC diet, for endometriosis. A lot of times we'll talk about a diet high in greens, such as kale and broccoli, to keep really that estrogen in your body down. We talk a lot about anti-inflammatory diet for patients. And then the bladder, IC diet, and then just lots of water, counterintuitively cutting out the coffee and the alcohol, and just lots of water is kind of a lot of talk about that. So quite a bit of lifestyle. Rehab is function. So our whole thing is quality of life. That's our whole mantra. So this is all kind of correlates with our training. And as we measure our progress, we do measure pain pre and post our treatment, but the other thing we measure is functional pelvic pain scale. So it's about exercise, work, being able to sit and work and have intercourse and bowels and bladder and all that good stuff. How about you? What about you?
We cover a lot of very similar things. Definitely exercise, making modifications. Like if I have somebody that's doing a lot of really heavy workouts, then we might back off on that for a little bit and focus more on yoga or walking or something, like you said, something they enjoy. Because if I tell somebody to go and do the elliptical, but they hate the elliptical or they don't have access to an elliptical, then that's going to be really pointless for them. So we try to find something that they like, whether that's me kind of developing an exercise program for them, or I love yoga with Adrienne. I send people to her website all the time. That's definitely big for me. And then, like you said, nutrition is a big part of it as well. So my biggest thing is focusing on reducing those bladder irritants, especially if they're having any of the urinary symptoms, so frequency or urgency, and increasing water intake, which I'm sure y'all get the same faces made at you when you have someone come in and they're like, well, I'm only drinking 16 ounces of water because I'm having to pee all the time or I'm having urinary leakage. And then you're like, oh, well, you need to drink, way more water. And they're like, why would I do that? Why would I ever do that? But then it's so interesting because then they increase their water and they're like, this is so much better. I'm like, well, your bladder doesn't hate you anymore. So it's a good result. And then, again, bowels. And I think that's another thing. People don't think about how the bowels are connected to urinary or vaginal or testicular issues at all. Like, even though it all fits right there. But I'll start, asking about stool consistency and what their diet looks like. And they're looking at me like, why do you care about what I eat?
I told you I have pain with intercourse.
Difference. Yeah, exactly. They're like, why do you care what my poop looks like? So, but it really, like, sometimes if you clear up the constipation and so then the muscles can actually calm down, then it's incredible. And it's crazy how many people that have the pelvic pain, once you start digging, like you said, being a detective, they'll tell you, oh, I've had constipation since I was 10 years old. Like, oh, there it is. And so, and they think that's just what they have to live with. And that's what's frustrating to me, is that so many people, I think, come to y'all and come to me and say, I don't really know if you're gonna be able to help me, but I'm kind of desperate. So somebody told me that y'all helped my friend, and that's how I ended up seeing y'all. Like, these people a lot of times come in pretty hopeless and have seen so many people before us, and which is frustrating to me. But I think we're 100%. Getting the word out there and more people are finding help. But I think addressing the lifestyle issues is so important, because those are things they can actually change in their day-to-day and not just have to take a pill for the rest of their life or something like that, or have to have a major surgery. So I think the lifestyle modifications are super important for that reason.
100%. Yeah, I completely agree. A lot of talk about the squatty potty.
Yeah.
No, but you're right. It's just amazing when, honestly, a lot of urgency, frequency of the bladder is their primary complaint, but then you normalize their bowels and their bladder just is a lot happier. I mean, I describe it, it's like Manhattan in there. It's not a lot of space. So if the bowels aren't doing well, it's putting a lot of pressure on that bladder.
That's a perfect description.
Completely agree. It's so important. And it's just, sometimes it's great when that simple fix can really make a big difference. And not only, even just in maintenance too, once patients, again, at our follow-up after our doing so well, it's a common thing for flaring bowels. So we really focus on, that bowel health and to really continue doing well.
And I know y'all do, y'all recommend vaginal probiotics relatively often. Is that true?
We do.
Can you tell me a little bit about those?
Right, and usually we'll prescribe those if patients have a history of recurrent UTIs or recurrent yeast infections. Then we're trying to normalize the bacterial flora, because if the pH is off, if it's acidic, it can be an environment for both bacterial infections and yeast. So a lot of times we'll prescribe those. Sometimes we'll prescribe them for a week or two with boric acid, and then alone, long term, more just the suppositories alone. So we'll do that. And then with yeast infections, we talk a lot about low sugar diet, just because overall yeast really proliferates in sugar. So we combine that with the suppositories, and it helps.
Yeah, I think focusing on the anti-inflammatory diet, like that's been something more recently that I've been really trying to encourage patients to consider. It can feel really restrictive, which is hard. So they definitely have to be in a good place to make a big diet change. But I've had a couple patients that have taken out either gluten, dairy, or sugar, or a combination, and it's crazy the difference they'll notice in their pain.
Yes, 100%. I feel sometimes, it is a little bit more of a subtle long-term approach, but it really works if you stick to it. And of course, you're going to cheat once in a while. It's more just about your global perspective, So that's what we always talk about. You have to live life too. So
yes. Oh, absolutely. Yeah. I'll usually tell people if you can stick to it really strongly for about a month, then that should help things reset a little bit. And then your body should be able to tolerate the cheat days and things like that a little bit better.
Completely agree.
Yeah.
Yeah, completely agree.
One thing you'll see a lot is endometriosis, and that involves a lot of coordination between y'all and pelvic floor PT and gynecologists. So how do y'all usually work with the gynecologist in that area?
Yes, great question. So, I mean, typically, honestly, we're really on the front lines of endo as physiatrists, which, at first I didn't, realize this 7 years ago, but really, the more we practice, the more we realize. So we try a non-operative approach first, really, our basic protocol with pelvic floor PT, the injections, suppositories, lifestyle changes, acupuncture sometimes, and see how patients do. And if they do well, we'll say, okay, great, here's your yoga program. If you flare, do ice heat, so give them basically, you're doing great, call me if you need me. If they, do a little bit better, but not really where they need to be, we have a high suspicion for endo, which is mostly from history. We can tell a lot from a history, and they're not really responding as most patients would, because most patients do release. The nerves get better, the muscles get better. If there's no underlying chronic pathology that's kind of fighting that inflammation around the nerves, they really should respond. So if they're not responding as well as our typical patient, then we think endo, and we'll send them to an endo gynecologist who's an endosurgeon, who's a specialist in it, who does a proper excision surgery. To really remove the cells of endometriosis, because that really does help. It's a systemic inflammatory disease process, endometriosis, right? Yeah, so it's quite complicated in its connections to both the nervous system and the HPA axis and the hormonal system. It's quite complicated disease process that the medical professionals are still really investigating. So we'll get the surgery and then see how they do post-operatively. And that's how we work with them. We'll refer for the surgery if they need it, because you really can tell the difference post-op after that kind of pro-inflammatory state has been removed. That inflammation and the upregulation of the nervous system can calm down nicely. Yeah, I totally agree. And I think that's what's really cool about our practice and having y'all just down the street, is because we'll be able to treat those women like through the whole spectrum of care, which I think is really cool. So like you said, starting more conservative, okay, let's see what improvements we see. And then if they do need the surgery, then we have people like Dr. Shepard, who is trained in that minimally invasive excision surgery. So she can take over that part, and then they follow up with us, do yoga, things like that. And it's just all in one little area, which is great. Yeah, no, I'm excited. It's Dr. Shepherd and you are just fantastic resources for for our Dallas patients. It's wonderful. It's how it should be done. That multimodal, multidisciplinary approach for these patients is what really works. So it's just an amazing care that you guys have.
Thanks. Yeah, I think taking it from different approaches is so important because we're all going to look at things a little bit differently and we all have strengths in certain areas. And so I think if you take it from one scope, then it's hard not to get kind of tunnel vision on what your scope is. And so I think that's why it's so important to look at it from all those different angles, because I think with almost any pelvic condition, they're just complicated. It is not just a pulled hamstring. Like that's not what's going on. It's a muscle dysfunction, a nervous system dysfunction, fascial dysfunction, and then like we were talking about earlier, issues with nutrition and hydration, exercise modifications. There's just way too many things for one person to be able to fix everything.
100% agree. Completely agree. And it's just conceptually putting it all together. Essentially our organ for pelvic rehabilitation medicine, what we're looking at is the pelvic floor muscles and nerves. And then you have different specialties that are looking at the organ system. So, together we all work nicely, but we do need each other. And then there's a lot of, subconscious tensing on top of it all, the pelvic floor muscles, right? That are squeezing the nerve even more. And, it's hard to know if, sometimes those uncomfortable pain symptoms or bladder or bowel symptoms can cause that tension because you're not comfortable. So working on decreasing the tension and being awareness that you're squeezing the muscles, right? And then just any anxiety. Some people hold their tension and anxiety in their neck, and then others hold it in their pelvis and pelvic floor. So we usually all hold it somewhere. So it's just the awareness and the body awareness and just constantly releasing.
Yeah, that's one thing I'll have my patients do often, especially if I know they have a history of anxiety or I can just tell there's somebody that holds their tension. You said the same two examples I always give. I'm like, it's either in their upper traps in their neck or it's in your pelvis. For whatever reason that is, that's where tension seems to land for most people. And so what I'll usually tell people to do is like, when you look at the clock, if the hour's different, if the hour has changed, then do like a body scan. So I'll tell them to really just stop for a minute, take a couple deep breaths and scan their body, just mentally checking in to see where they're holding. And they'll usually find, oh, I really like stuck in my abdomen for no apparent reason, or I really squeezed my glutes, or I'm squeezing my pelvic floor, but they don't even notice it until they really consciously release it.
Completely. I love that. I love the body scan idea. That's fantastic. I love that. I typically ask them to do 10 sets of the diaphragmatic breathing in and out. I usually say when you wake up in the morning, because everybody has 15 seconds at night before bed, and then try and take at least one break and you stand up from your chair, stop sitting, and do your breathing and walk around. But I love the body scan idea. Let's start. That's a great one.
Thanks. Yeah, same thing. I love reminding people to just do that diaphragmatic breathing throughout the day. And it's so interesting how many people come back and they're like, I didn't think the breathing would change anything at all, but it's made a huge difference. Like sometimes it's literally just the breathing that makes all the difference for people.
Yeah, 100%. It's yes. In this day and age, it's challenging to breathe correctly, naturally.
Yes. Yes. For sure.
I agree. I completely agree.
What do follow-ups look like for y'all? So if they have like the series of 6 injections, then how often do they come back to visit?
It does depend. Typically, after the series of 6, we don't see patients for 6 weeks because conceptually what we're doing is just making a better environment really for the nerves to not be so restricted and inflamed. So once we create a better environment, it takes some time for them to heal themselves, which they do now that they have more blood flow, less inflammation, right? So then we'll see them back at 6 weeks. They're doing pelvic floor PT throughout the entire program, the whole time. And then after that, it's usually 3 months. We'll say, we'll see you back in 3 months. And then if they're doing well at 3 months, it's as needed. It's, come back if you need me.
Gotcha.
Yeah.
Yeah, that's awesome.
How do you do it? What's your follow-up plan?
So typically it depends on a lot of factors. But with most of my pelvic pain patients, seeing them once a week to every other week, because sometimes scheduling financially, they need to kind of spread out the appointments a little bit. But I would say seeing patients once a week for about 8 weeks is the most helpful. That's probably where I see the quickest and most effective results. And then from there, tapering it off. So say I see them for once a week to every other week for 8 weeks, then we might start pushing it out to every 3 weeks, and then I might see them once a month. But I would say it's not uncommon for me to see patients with pelvic pain for about 4 to 5 months, but with visits spread out in that last 3 months.
Okay. Yeah.
Yeah.
Right.
And again, that just depends. I've had some patients where I see them, once a week for 6 weeks and everything is good to go. And then some patients, it just takes a lot longer, like you said, to get them out of that upregulated nervous system.
Exactly. Yeah, that's usually the trickier. It's usually the chronicity. It's a lot easier to get patients better when it hasn't been going on for that long, right? So it's just that chronicity just continues in that cycle of upregulating their nervous system. Completely agree.
Yeah, which is what's hard because most people don't find us until they are really chronic. So whenever I have someone that comes in and they're like, oh, this started like 2-3 months ago, I'm like, really? I'm like, that's awesome.
It's great. You're going to be fine. Don't worry, we got this.
Like, exactly. I'm like, it's going to be great. Like, I've had patients that have had this for 20 years. So
that's same here. It's really exciting when you get them early because the confidence level it's great. The turnaround time is good.
Oh, definitely. And then it looks like, I think we had a question on here. Let me find it. Okay, so Wendy asked, in what ways have you both found dry needling to be useful in treatment of pelvic floor dysfunction? What have y'all seen as far as dry needling goes?
I am a huge fan. I love it. I love it because conceptually, particularly around obturator canal, because it goes with what we're trying to do is release those fascial restrictions and increase blood flow to the nerve. So for us, I see a big help when they have concomitant dry needling. How about you?
Yeah, I would totally agree. Whenever I first learned dry needling, I was honestly like, I'll probably use this sometimes, but it's not going to be like my go-to for everything. But ever since I've been doing it, I mean, people just get results and relief almost immediately. So it's not the most comfortable thing to have done right off the bat, but usually the pain is very temporary and people will feel a little sore after, but it works so well. So we'll use it a lot in, I use it a lot in the glute med area. So people that are having like SI joint pain, even pelvic floor pain, sometimes just needling that glute med, it can be super helpful and release a lot of that tension. And then also, like you said, in the obturator internus, it's pretty effective there. And then I'll also do a fascial remodeling approach. So basically, instead of pistoning the needle, what you're doing instead is you insert the needle and then you twist it. And you just let it sit there for about 3 to 5 minutes, basically until the achiness that they feel goes away. And what it's doing is it winds up the fascia and then it's essentially unwinding it as it releases. So again, getting blood flow to the area, either with the pistoning approach or with the fascial remodeling approach. That's the goal, is to get blood flow there. But yeah, I have loved dry needling for most of my patients. The only people that I think don't respond well to it is if they're really needle phobic, then it's hard for them to get past that sometimes. And so then if it's going to be more anxiety producing for them, then they're just going to tense up more and it's not going to be helpful. So that's really one of the only times, unless I have some contraindication, that I wouldn't consider it. Let me see. Do most of the pelvic floor PTs that you send to do dry needling?
No, I would say it's a mixture.
Okay.
Some do, some don't. Yeah, and I agree. It's completely tailored to the patient. Quite a few do, though. I would say it's fairly common across the country. At this point, we are in so many cities that we're seeing kind of how it works across the country. But yeah, it's fairly common.
Yeah. And the other area I would say, I don't always needle it but I do a lot of manual work is in those inner thigh muscles. Do y'all see a lot of tension there related with pelvic pain?
The adductors, yes,
yeah,
100%. Yeah, that's a good spot for it, right? To treat with, or sometimes acupuncture also is an option.
Yeah, and I think that area gets so tight, especially in our patients with urinary incontinence, because they cross their legs so often to try to keep them from peeing themselves. And so it's interesting that like when we get them out of that habit of crossing their legs all the time and squeezing their legs together, that suddenly their leakage might actually get better because they're not increasing all this pressure and tension right around the pelvic floor.
Completely agree.
Yeah. Anything else we haven't touched on or that you want to talk about?
No, I mean, I think that conceptually, just for patients to know that you don't have to live with these symptoms of bowel, bladder, pain with intercourse, pelvic pain in general. There's really quite a few resources out there for you, and the treatment is available. So I really just, the message of please, reach out and be your best advocate, and you're the best proponent of yourself and your symptoms and your quality of life.
Yeah. And what's the best way for people to get a hold of your office or make an appointment?
Yep, so you go to Pelvic Rehabilitation Medicine.com. So basically, if you just Google Pelvic Rehabilitation Medicine or pelvicrehabilitation.com, there's a contact email and or a phone number. Perfect. And you can call or just email the contact email. And we're happy to do, either a telehealth consult or in person.
Okay, awesome. Yeah. Our website is under construction right now. So the best way to get a hold of us is either going through Instagram or Facebook. If you find Sanctum Med and Wellness on there, you can send us a message and we'll get back to people that way. Or people can email me directly. It's Allison, ALLISON @sanctumwell.com. And I'll make sure to get you directed to the correct person. But I'm so excited that we got to do this. Thank you so much for coming on.
Thank you, Allison. I'm really excited about Sanctum Wellness. This is really exciting, and I can't wait to actually see it in person.
Thank you. Yes, we'll have to have you out there soon. Well, have a happy holidays, and we'll talk soon, okay?
Thank you. Bye, Allison. Take care.
Bye. You too.